Good morning.
Hello.
It's the hardcore people who are staying. Either that or you have a flight and you just don't want to sit in the airport. So you decided to come here. Hi, I'm Catherine. This is Elvar. We're going to be talking about patient identity. And I'm sure this week you've heard a lot about workforce identity. So this is focused on what you and I all are, which is we're all patients. So you're going to get something out of this presentation. So I'd like to start off with this story. This is Pat Dawson. Pat Dawson is a 73-year-old female. She wasn't feeling well. She was at home. Her son came over, was alarmed at her condition, called an ambulance. The ambulance came, took her to the hospital. While arriving at the hospital, she had a cardiac event, and the caregivers resuscitated her and put her in the cardiac intensive care unit, where she was, had lab works, had imaging. The next day, she continued to feel poorly, and she suffered another cardiac event. And the clinicians went and looked at the electronic medical record, and they noticed that she had a DNR notification on her record, and DNR means do not resuscitate. And so they quit giving her life-saving measures. And the doctor went and told the son, "I'm sorry, your mother has passed." He was surprised at this, and we said, "What happened?" He said, "Well, your mom has a DNR." And he said, "No, why would she have a DNR? She was perfectly healthy." That doesn't make any sense. And so they went and looked at her record, and it turns out that there is another Pat Dawson at that hospital who was a 90-some-year-old man who had terminal cancer. And so, yes?
Sorry to interrupt, but got a weird feedback.
Yeah, I am too.
Hi.
Sorry to see you now.
But this, I had mine off here. I had mine off, and it was doing the same thing. But I believe.
How about that? Is that better? Okay.
Sorry.
No, I want you to hear my stories. So anyway, obviously the DNR was for the wrong person, and this woman passed. So that's just an indication of what happens when you have bad patient identity. In other industry sectors, that could lead to a financial loss, or it could lead to, other breaches of information. In this case, bad identity can lead to patient harm or death. So what causes this sort of dilemma? There are basically three things that impact patient misidentification. One is a concept called overlays. Overlays is when two records, two different people, are commingled together, like Pat Dawson. Two records are commingled into a single record, and they usually have the same name or date of birth, things like that. The other one is duplicates, where there's multiple records for the same person. We don't want that either. And then finally, there's just an inability to do really good identity confirmation. And that's obviously what happened here also with Pat Dawson. They didn't confirm, she's female. She's 73, she wasn't 98. So we're going to talk today about the four foundational services or pillars of patient identity. And I'm going to take two of these, and Elvar's going to take the other two. So I'm going to start off with identity resolution. Identity resolution is the process or the service that enables a 360-degree view of the patient's identity across the enterprise. This is solved usually by a service within the healthcare enterprise known as an Enterprise Master Patient Index, or an EMPI. Sometimes in some organizations they call this a Master Data Management Service. But the goal of this service is to apply algorithms to automatically analyze your PII, your name, your address, your phone number, to determine if this John Smith is the same as this John Smith. And if they are, it will merge them or link them together. And I'm still getting that feedback. Are you?
Are you guys hearing that?
Yeah.
Yeah.
Oh, okay. Well, sorry about that. The other thing that the MPI does is it creates what's known as a golden record, or the source of truth for the PII in the healthcare ecosystem. There's also a team of people that work with this system. They're often known as patient identity management. Sometimes they're called data stewards. But these are the people who can manually reconcile identities. So it's not just left up to the algorithm to figure it out. There's human intervention as well. You often don't see that in other industry sectors, but it's definitely present in healthcare. So what we have, this is a typical hospital. You have all of these different systems that are feeding their information into the EMPI. And the information that they're feeding is name, address, phone number, date of birth, sometimes social security number, although most organizations are getting away from that. If they do feed social, it tends to be like the last 4 or 5 digits. They really don't want to dabble in social security numbers anymore. And it's just this small set of data that allows these algorithms to figure out, is this person the same as that person? And as you can imagine, our data changes over time. So my address changes, my phone number changes, my last name changes. And that's when it becomes really difficult to try to reconcile and understand that Sally Smith is the same as Sally Jones and she moved. And so not only do you have to keep current data, but you also have to keep historical data. And now I'm going to turn it over to Elvar, and he's going to speak about identity assurance. There it is. And then you can click.
It's right
You want me to
left.
do it?
Sure.
Okay.
That's okay. Elvar Olafsson, Jacobson ID. I don't know if you caught that earlier, Catherine Schulten, Walmart. The second pillar in this foundation is identity assurance. There are no federal regulations in regards to this subject. And so what happened, and I will try to keep this short, I'd rather keep some time at the end for question and answers. But given that there was no federal regulations to this thought, there was a group of smart people that came together and formed an alliance that you know as HL7, FHIR, and other related working groups that came up with a list of assurance level standards that could increase the level of assurance for identity for patients, given sort of like what Catherine was saying, and it just so happens that there are other reasons for it as well. Why did they do this initially? Well, one obvious one is that we're dealing with critical critical components of human life, right? So we're talking about records connected to a patient and so on and so forth, as Catherine mentioned earlier. And second one would be effectively care for the patients. If you can't identify a patient effectively, how can you actually effectively care for them? This list is again formed by these working groups, and these are not recognized by or endorsed by NIST, the NIST standards, but it's coming close to it. There's if you think of, I want to bring out an example here. If you think of patients or a human interaction with another entity like Walmart, there's a one-to-one relationship. There's really a one-to-one relationship between me and my relationship with Walmart. In healthcare, there is no such thing. It's one-to-many. So now you have multiple records in multiple different locations for one patient. However, they need to treat it like it's a one-to-one relationship. Otherwise, how can it be effective? I go to my physician, I need to get something done. I have personally suffered from a stroke. There's other things that have happened in my life, and when I go to a certain physician or specialty office, they can't pull up that record if I'm going to one place versus another. And that's not even mentioning the fact that in these large healthcare systems where there's constant acquisitions, there's different databases, data sources, different MRN numbers, different records. So like, how do you know which record belongs to me effectively? So the care for me as a patient is of course a huge one. Fortunately enough, and I'm going to just barely touch on this, is that there does exist a better level, and it's actually a NIST standard NIST IAL2 is the highest level standard. There's examples of it. I'd love to talk to you guys about that a little bit more in QA. From Cantera initiative that we can actually formulate a connection, effective connection between the patient and the records. And there are benefits to this for quality of care, correct records to the correct patient, facilitating an effective communication within the HIE for the patient for remote access to records and so on and so forth, and fraud reduction. And then it just so happens, and we've had significant experience of this for the last 10 plus years, that there's an enormous amount of, significant amount of cost savings for the health organization. Efficiencies in anywhere from efficiencies in check-in all the way to revenue cycle management. Revenue cycle management with the correct identification, most current information for that patient so that they can charge to the right place and so on and so forth. Yes, let's jump over to the next one. I'd like to talk about this just right towards the end, if that's okay.
Oh, okay.
Third pillar, which is authentication. There's been significant plays in an adoption to multi-factor authentication, so on and so forth. You know from my chart and others where you have, you're increasing the level of certainty for check-in for patients to their records. And there's been significant plays, of course, more in the realm of internal workers, physicians, e-prescribing, physicians connecting to portals, and other internal workers, as well as patients. That does not solve for the correct record being connected to the patient, but there's an ability to actually do that. But I'd like to leave a message here that we should be doing growing and enhancing the patient's level of assurance with these connections to the healthcare systems for these benefits that we mentioned earlier, that I'd love to talk about a little bit later here, but I'm going to pass it over to Catherine. There are some, maybe mention a couple of things here. You've probably heard of, there was the breach here with United Healthcare, Change Health, that it doesn't take much of a breach to create an enormous amount of damage. There was one email address that was hacked that was the primary cause of $2 billion of cost in that area. I'll pass it back to Catherine and look forward to having some QA here after.
And so the last pillar in patient identity is around authorization. In healthcare, authorization tends to take on a couple meanings. There's the concept of prior authorization, which is an activity that we have to go through with our insurance company to get our surgery paid for, our test paid for. That's not what this is about. This is authorization that the patient has to engage in. And there's really two types of authorizations that a patient can do. One is an acknowledgement, and we've all done this. We go to the doctors, and they give us the HIPAA notice of privacy practice. Sometimes it's a piece of paper, sometimes it's digital, and you're asked to sign your name. You do not have to sign your name on that, by the way. It's the acknowledgement is the fact that they gave it to you. The fact that they want you to sign it is really neither here nor there. It's just what they do. The other type of authorization are consents. And there's two types of consents. The one that you might be most used to is the informed consent. So informed consent is when the doctor is going to tell you, I'm going to do this service on you, these are the risks, this is what it might cost, et cetera, et cetera. You're informed about the entirety of what's going to happen, and you sign and you date it. So that is an actual consent to receive that service. You might also sign a consent to share your health information. So you go to a specialist and he's like, well, I'm going to share this information back with your primary care physician. You give consent for that to happen. You can also withdraw your consent. So if you don't want that information to be shared anymore, you can do that as well. So these are the types of consents that you usually see in a doctor's office. And the other final type of consent is what's known as an implied consent. And these are kind of tricky. An implied consent usually is presented in a way that looks like an OK button, or yes, or continue, or something like that. It's just very like, I just think I'm going through this form, but really when you click on OK or continue or next, you're actually providing a level of consent. So in this example, it's, what type of appointment do you want? And the person says in person or virtual, and they, agree. Well, that's a consent. They're agreeing I want to do an in-person visit versus a remote visit. And then the other aspect of authorization has to do with how they are signed. Now, most doctors' offices, not very sophisticated. Hospitals tend to be a bit more sophisticated. So it is quite likely that you have signed physical pieces of paper with a pen, but you could also have been presented a tablet. And when you sign the tablet, you're doing something like this. You just run your finger across the little bar and you draw a squiggle, and like that's your signature. Well, that's an e-signature. Anyone could have done it. Your cat could have done it. No one knows who did that, but it does show that there was some interaction with this form, as opposed to a digital signature, which I think we're all familiar with, which is really for these high-value transactions. These are the types of things you might be used to if you've purchased a home and you had to go on to DocuSign and you sign something. Those things are encrypted. They have a date and timestamp. Typically, the digital signatures require a specialized piece of software. We rarely see digital signatures in the healthcare space as a patient, but you might from time to time, especially if you were getting something that was experimental or there were known risks. The doctor would want you to have a digital signature so that they can say, you signed up for this, you knew the risks. So those very quickly are the foundations of healthcare. These four elements work together to ensure the right patients receiving the right service, ensures that only the right patient has access to their health information, what we call PHI, or personal health information. And this is necessary for accurate health information exchange between the disparate entities involved in your care, and also your health payer, and to you as the patient. So we ran through that very quickly, but we wanted to leave time at the end for Q&A. So thank you very much.
Questions?
What does Walmart have to do with healthcare? Would you believe that we have 140 million patients? We have 5,000 pharmacies, and we have about 3,000 vision centers. And in my day job, I'm responsible for the reconciliation of patient identities across the United States, so about 140 million patients. That's what I do in healthcare. I also work with my team members who do authentication, assurance, authorization. Yeah. It always comes as a surprise to people that Walmart has such a big footprint. But, Kroger and Target and, all these other entities that we think of as a retail establishment also have a healthcare footprint.
Go ahead.
Can you share a bit more about this modern environment, the recent
Yeah.
protocol? Do you know anything about it? How did it came into the picture? Who
Yeah.
architected that protocol? Any idea behind that, history behind it?
So if you remember the list, just briefly, not the details of it, but they worked hard these working groups worked hard to be able to actually functionally get it to a better level because the government wasn't doing anything about it. So effectively, the solution that you're asking about, it exists. It's been in practice for about 12 years. It has just been refined through Cantera here to the NIST IAL2, AAL2 levels. That means that you can actually authenticate at the highest level, or validate at the highest level, but then also ongoing authentication at the highest level and keep that. It's kind of like you form a relationship with Wells Fargo, you validate initially, and now they trust you every time that you come in, and it's at the highest governmental level. So why am I mentioning it? Why did it evolve into that? It's because they were working on this list, but it's cumbersome. So effectively, yes, I mean, theoretically, yes, it's a smart way to increase that assurance level, but it never reached the level, in our opinion, in our practice for many years, to be effective. Why? Well, how do you force a patient to identify themselves? They come and to check in as emergencies and stuff. They forget their wallet at home, this and that, blah, blah, blah. We actually have a worked on solution at that highest level that actually can be sent to your home. You can do it in your car at home. Takes under 2 minutes. You can assure yourself to that level through your mobile device. Then that mobile device carries through with you. So it captures your face, liveliness, compares data, your OCR, your driver's license. It's very effectively, no buttons touched, blah, blah. I mean, it's a very effective, very efficient method. So it does exist, and it's designed by experts that have been in the industry for a long time. I can go into more detail, but I need to cut, yeah.
Okay, one more question here.
Hi, I'm Andrew Hughes from the
Cantarian, I say, yeah, we recognize you. Yeah.
So I deal with insurance programs and dig deep into the state under 63. So this work, I think, came out of the HL7.
Yeah, HL7
Yes.
Fire Working Group. Yep,
Yeah.
this is their own proprietary. Yeah. This link, if you can go to it, has a really good explanation about these levels.
So I think this question is for Catherine, maybe. Why fractional levels? Was it patient harm or anti-fraud?
It was the recognition that in the healthcare space, in most instances, you have to accept all. You know, if you come in and you're sick, you have to be seen. But there's people who come in who are not from this country, people who come in who are in an altered mental state, people, you know, you get it. And so the idea was, well, what can we say is the best way to approach identity assurance for a community of individuals who aren't trying to set up a checking account, and so they have to follow KYC. But they're not trying to buy a hamburger either. So, you know, I have to find some level in here between these two distinct, you know, reaches of the continuum. And so this was seen as a way to meet the patient where they were with what they could accommodate and put some definition around it. Because up till now, what the regulation says is you have to verify the patient. What does that mean? I have to verify the patient. Like, you could do whatever. You could ask them a multiple choice question. So that's what this is.
Just a quick follow-on, I guess. Why does it matter that there's 1.4 to 1.5? Like, is it patient harm or is it fraud?
No, I think it was just a working group that probably went, in my opinion, went a little deep on this.
There was a disagreement between the two, and they just chronologically set it up this way.
The 6 and the 8s are the more useful levels because those facilitate resolution of the identity, and they also facilitate data exchange.
Yeah, so 1.4 and 1.5 is really about the metadata about the group.
Yeah, whereas 6 and 8 are more useful.
That's about the level data sheet.
Yeah.
And to give the rest of you a little bit of context, this gentleman was the cause of a lot of heartache for us.
We're not getting into our personal opinions about each other in the room.
No. We had it was a long, hefty process to get the certification, but the idea here is, and I think that's one of the takeaways here for today, and that is, hey, we're able to do it with NIST certification far more. If there's any HL7 people in here, significantly more assurance and significantly more effective and efficient. So, but that has taken a long time. It often takes a very long time to make something short and quick and easy and efficient, right?
Yeah, it's hard to make things easy. Any other questions? Yes.
Yeah. So, do you see on the lines of credit history? Do you see in healthcare modernizing in a way that patient has their medical history on a single ID in future, or is it like
not in the United States? I don't see it.
Because that would be amazing.
I mean, that's
treating
yeah.
For the first time, or the
Yeah,
patient is not conscious, you just pull the history
If we were in the UK, if we were in a country that had, they call it socialized medicine. I call it, the way you should be doing medicine. But yes, if we were in other countries and that's how you did it, you would all be tied to a single national health identifier. In the US, no. It's a scattered.
Yeah. So even though we're very advanced and awesome physicians and so on and so forth, free market brings about complications, and that's one of them. Huge complications.
But that comes up all the time. It's always been asked for, and people who have worked in this space, they say, well, why don't we do that? And it's just the nature of how healthcare grew up.
Really quickly, it's really what has driven us to do it is actually questions. The healthcare systems just don't know that this exists, and the simplicity. So we're trying to penetrate that market right now. But if you think about it, the patients really, they own their data. They don't own the platform and the data. So they're entitled to their CCDs, CCRs, so on and so forth, but in a format like of an XML, you can't, can you use it? The smart healthcare systems are actually now connecting and partnering with health information exchanges. So it goes from health information exchanges to EMPIs down to the healthcare systems, right? And then they effectively now are able to, thank you, to share the data effectively, so that the patient can actually go to Thanksgiving in a different city, go to another healthcare system, allow that physician or that physician group to access their data effectively.
All right, we're out of time.
Thank you.
Very much.